Come on, turn. All right, it's 5:59. Close enough. Good evening, everyone. This is Dr. Garais. This is MED210, 7NAX, Thursday evening, and it is November 5th, and it is now week 4. Next week is your midterm, week 5. So what is due this evening? Task 3, discussion 3, lesson 3. And next week, only task 4 and lesson 4. No discussion will be for extra credit for your midterm exam. Your midterm exam will be at 6 p.m. next week on the 12th. And around 5:55 on the 12th, you're going to look. You don't have to go into Zoom. You're just going to look here in announcements, and there should be, it'll say like week 5 midterm exam. I'll also have a recorded lecture so that we don't miss out on any week 5 material as well. So make sure you're logging in the night of the exam next week. The exam starts at 6 p.m. It will end at 7:15 p.m. promptly. And the only thing that I need is numbers 1 through 50 with letters in an email. And all of that will be in the instructions in announcements for next Thursday evening. And then there'll be grades will be done by Saturday, 12 noon of next week, of next Saturday. And that's your midterm grade. Now, your midterm grade is not a real grade yet, but it gives you an idea where you stand in the course relative to its completion. And remember, it's the holiday season coming up. We're going to try to wrap things up by week 9. But officially, we are done week 10 in December. But we're gonna try to work things out because I know a lot of people are going on vacation and such and such. All right, so let's get on with the show. What are we doing this week? If we look here, we're going to be talking about the renal system or the kidney system. And the important parts of the kidney system, one of the important parts of the renal system is the formation of urine. So we're going to learn this evening what is urine, how do we make it, what is the function of this all, and the formation of urine is just part of what the kidney does for us. It does several things. Now, there also is an endocrine regulation of kidney function that we kind of already talked about in the renin, angiotensin, aldosterone system. So the RAA, it's in 2 chapters. So what does that tell you about the midterm? It screams must know topic. It's going to be on there. Don't do the urinary physiology lab, but as I stated, these Carolina notes, they have nice supplementary notes here. There you go. That will also help you in your studies. So overall, urinary system structure and function, all the players and what they do, kidney structure and function specifically, and also microscopically, we're going to be looking at the nephron, also known as the functional unit of the kidney. And I may touch on endocrine regulation, but you already know that from our previous lecture on the RAA system. And if you want me to go over that again at the end in the Q&A, we can, just shout out and then we can go over that. So again, like I stated, I'm going to try to use our OpenStax textbook a little bit more because, hey, it's there, might as well use it. So I'm going to go over renal, see if I can find it. I can't remember what number. Appendicular, joints, muscle, tissue, muscle, regulation, nervous system, nervous, somatic, nervous, autonomic. Where? Fluids and transports, cardiovascular. It's got to be past the GI. Respiratory, digestive, metabolic, here you go. Urinary system, chapter 25 in your open stacks. So when you look at when you look at it, we already know that. What does it do? It filters the blood. We already know that, and we already know that urine is a form of waste. Now, to expand on the definition of waste, waste is anything that your body can't use, because remember, too much of a good thing becomes a bad thing, and that's why we have homeostasis. We can't have too little amount of things, and we can't have too much of things. And anything that's too much, our body would like to get rid of it. Other things that the kidney does is regulation of pH and the pH balance, right? We already know that the lungs also deals with that, and there is a metabolic homeostasis going on with our kidneys, because our kidneys can throw out H pluses and OH minuses just in the same way our lungs throw out hydroxide ion with carbon dioxide. Another thing that the blood pressure, that the kidney does is blood pressure. We already kind of know, because of the RAA system, that kidneys can throw out salt or can retain salt. And if you recall, the antidiuretic hormone, that's the signal for the kidney to retain salt. And another way to look at it is it's a signal for your kidney to anti-diurese, which is don't pee. So another thing that the kidney does is monitor all blood flow, because all the blood flow has to go through the kidney at one point during the day. So the kidney can also sense when you're a little bit low on blood. And erythropoietin, if you recall from the endocrine lecture, erythropoietin is signals your bones to make blood or stimulate red blood cell production in your red bone marrow in your blood, and that is regulated by the kidneys. And last but not least, again, kidneys keep things and throw out things. So that's also vitamin D and vitamin D processing, which is also very important to not only skin, but also bone as well. So you could see how vital kidneys are. And whoever built us with two of them, just in case you can live without one, just in case the other one would fail. But in a perfect world, you really need the both of them. And you could see how, if you remove one, or if you stress out one or both, you could see how many pathologies are related to kidney failure. I am part of the local National Kidney Foundation. I'm a lifetime member. Before COVID, we used to have these monthly events to not only raise awareness. It's a killer, and especially diabetic nephropathy is a big thing. And it's almost, when you get diagnosed with diabetes, it's almost a guarantee. If you don't control your diabetes within 10 years, you will get kidney problems and will lead to kidney failure. And those problems are listed here. Again, back to how we should look at things. We should look at things as, if I know the function, if I know what would go wrong, you know how normal is, all you have to do is just do the exact opposite of what normal is. So you could see how many things that kidneys do. And this also looks like a beautiful all of the above question, isn't it, regarding which of the following functions are functions of the kidneys. So they're a big thing in homeostasis. It keeps us in check for a whole bunch of things. So what is urine? Okay, we already talked about urine in the sense that it is waste. You got to get rid of it because it has things in it that's too much. And one of the main things that it has too much of is nitrites and ammonia and what they call nitrogenous waste. Our bodies were carbon, hydrogen, oxygen, right? And we also have a little bit of nitrogen. We don't need all of that nitrogen, so we got to get rid of it, and we get rid of it in the form of urine. And here's your urine can be examined, or urinalysis is broken down into three parts. You have your chemical analysis, your physical analysis, and your microscopic analysis. So physically, the thing that you're looking at typically is color and odor. The color can anywhere be pale to a deep amber or a dark yellow. Odor, I don't quite agree with the odor characteristics of normal urine. We all know what urine smells like urine. Actually, clinically, normal urine should smell like normal, normal urine, and that term is called aromatic. Now, what does abnormal urine smell like? For example, if we're throwing out way too many ketones, and urine indirectly is a way to tell what's also going on in the blood, because if you got way too many things in blood, for example, proteins or sugar, if I have way too much sugar in my blood, right, what's my body going to want to do? It's going to want to throw it out because it's too much. So if I have an uncontrolled diabetic, they're going to have way too much glucose in their blood, and they'll have abnormal results in their urine. They're going to have maybe +1, +2 glucose in their urine. So you could see that how urine and urinalysis is a very neat diagnostic tool. So the pH is it can be a little bit acidic, or it can be a little bit basic. Now the neat thing about pH is that we kind of play with the chemistry with the pH, or how acidic something is, or how alkaline or basic something is. We do that. We use that strategy when we want to try to get rid of certain drugs and certain pharmacologic properties out of your urine. Volume, it could be really low, or it could be really, really high, depending on how much is your intake. Kohler, odor, clarity is another thing that we look at in the physical properties. So the physical properties are up here: color, odor, volume, and clarity. And it should be clear. If it's cloudy, odds are the most common is hyperlipidemia as the reason why the urine is cloudy. So all these other things, pH, specific gravity, osmolarity, all of these things are the chemical properties. And SG is, it's a chemical way of looking at something on how heavy something is. 1.000 is water. And your specific, there only should be some solutes in your urine. There should be some solid things. Because if you notice, should there be any white blood cells, or no, not too many. Should there be any enzymes of the white blood cells? No. Proteins? No. Bilirubin, very small trace amounts. There shouldn't be ketones. There shouldn't be blood unless it's a female patient and it's their menstrual cycle. And there shouldn't be glucose. There's not a lot, but when you think about all of these things like blood and glucose and proteins, they're things that we typically want. So unless they're in abnormal amounts in your blood, we don't throw them out. So what kind of question could I ask? I just asked, like, what's normal? And, but, it's a nice side question. But typically what's normal is there shouldn't be that much in your urine, because your urine, its function is to throw out water or excess water and nitrogenous waste, right? So there shouldn't be all these other things in it. Depending on the color of urine, and this is not, you can tell if the patient, you can kind of tell the patient's hydrated or dehydrated, but the better way to look at the hydration status of your patient is to look at the percentage of plasma to your red blood cells, and that's called your hematocrit in your blood. But it's just a quick thing you can also do. This is what we're afraid of. We're afraid of this: oliguria, then anuria, and this is the reason why when you're monitoring fluids in your patient, intake and outtake, you can't get lazy, and especially late at night, because the second you start seeing oliguria and anuria, oliguria is this is already pending kidney failure. So when it gets down to like 200, 100 ml per day, we get very excited about the urine output. Typically, it should be, give or take about a liter a day, depending on the size of the patient. So that's urine. And typically, we get the urine via a clean catch system, meaning we don't want to take the first fluid that comes out when the patient starts peeing. Another word is voiding, right? Because if you can see here, let's look at this. Let's see if I can get this bigger. If you see here, before the urine comes out and has to go into the urinary bladder in both the female and the male, you could see that there's a pathway there where there could be some old and stagnant urine, and urine, when it comes out, should be sterile, meaning no bacteria. But if you let urine hang out for a little while, like especially in a warm, dark environment, like this urethra here and this urethra here, then then you could have a false positive for a bacterial infection or an STD. So you ask the patient to urinate first and then catch it in the middle. You could also see that how very short the urethra is in the female patient, and the urethra is the tube coming from the urinary bladder to the outside world. But typically in the male patient, it's a little bit longer. And also the proximity of the female anus and the urethral orifice right here, it's close. So even when adhering to very good hygiene, there is a greater risk of urinary tract infection for our female patient versus our male patient. And it's because of the anatomy, as you can see here. So let's look at the overall picture. So these are, before we get to the kidneys, these are the players of our urinary system. You have your ureters, and they're a very thin tube, and they're covered with smooth muscle. And they bring from the kidneys, and you have two of them, to your urinary bladder, which is here. And if you could see, your urinary bladder is transitional muscle. So it can be as small as a golf ball and as big as a 2-liter bottle of your favorite drink, whatever that may be. So the reason why the ureters have a muscular lining is because the ureters perform peristalsis. They kind of milk or push down the urine into this temporary holding area. And remember, the bladder has to be temporary, because if you let urine sit here for a while, it's going to start develop, even though urine comes out, in theory, it comes out sterile with little to no bacteria. This is a warm, dark environment with water and some trace nutrients. Give it time, and this will start making a nice little culture for bacteria. And that's the reason why you always tell your children, or you tell people, hey, when you feel like peeing, go pee, don't hold it in, right? Now you have both an internal and external sphincter. As we stated in previous lectures, sphincters are just circular muscles that surround the tube and act like valves. Now, you have control, you have semi-control of these internal and external sphincters. But once the pressure from the detrusor muscles of your urinary bladder start pushing, eventually you're going to pee, okay? And then it goes, of course, into your urethra. So you have ureters, 2 of them, 1 urinary bladder, and then you have 1 urethra. Now, you can also see a related pathology regarding urinary incontinence. Let's say mommy has, a lot of children. Let's go back to this other picture. There is the pelvic floor that's held in with a whole bunch of muscles. But if there's a lot of baby here, baby, no baby, baby, no baby. What happens to the elasticity of the pelvic floor here? Well, you're going to have a vaginal prolapse, rectal prolapse, and you might even have urethral prolapse, meaning these tubes will start sliding out and outward. And the tubes also, when they slide outward, let's say we have baby, no baby, baby, no baby, these muscles here as well, they get stretched and won't be able to close this. And that's why you have urinary incontinence especially with multigravid patients. Micturition. Micturition is another word for voiding or urination. And do recall, well, I don't think I had that lecture yet. A reflex is something that doesn't require your brain. So because you have some level of voluntary control, as I mentioned earlier, but when that bladder fills, the reflex will take over. It'll push, and it goes, and it'll cause you a significant amount of pain. And it's also innervated by your sacral nerves. That's why when you have a sacral spine fracture, or what they call a saddle injury, you get a saddle injury, like you're riding a horse. It's typically where people who bounce up and down on their motorcycle too high. This will cause incontinence. It'll also cause erectile dysfunction and a whole bunch of urinary dysfunction here. As you can see here, like if I fracture my sacrum, and all these sacral nerves come down here and innervate this. Your ureters, we already talked about, they have this layer of smooth muscle, and smooth muscle is a muscle that you cannot control. You cannot tell your ureters like, hey, stop bringing urine down. It'll go there by itself, and it's part and parcel of the micturition, or the voiding, or the urinary reflex. And remember, reflex does not require a brain. It requires ascending tract, and it requires an interneuron in your spinal cord and a descending tract, and that's it. So the key thing is, don't fight when you have to pee. You gotta go, just go. All right, and you will feel very, very sorry if you don't. And all of us have been in that situation. Now, if you look at this, we have two kidneys, and they're located around your 10th rib, peritoneally, retroperitoneally. So you have your peritoneum, which covers the front part of your abdomen. So your kidneys are in the back. And again, since they're so important, whoever designed us designed us pretty smart. And another thing they put back there is a renal fat pad, so that any shock to the back there, or any fall or anything, can protect these two. Now, your kidneys, one of them is going to be lower than the other, and most likely it's the right one, because your right kidney, now here they didn't really show it too well, but the right one's going to be a little bit lower than your left because of the size of your liver. Okay, and you can see here the kidneys, and then are now connected to the ureters that we talked about in a moment. So right off the bat, can I easily take this picture, erase it, A, B, C, D, E, F, G, and then that could be part of your midterm? Yes, very easily, right? So in your best interest to do what? Grab up one of these, or you can look online, like a gross anatomy kidney quiz, right? And just practice. Imagine just practicing 5 to 10 minutes a day until next week. Then you'll get this all down. So let's look at, if you look at your kidney, has a specific shape with this indentation here. And this indentation is called your renal hilum. You might even see in a textbooks it called hilus, potato. But for our textbook, it's your renal hilum. And within your hilum, you have your renal artery, because it's red, right? And it's coming from the heart. And your renal vein, it's blue, and it's going towards your heart. So Everything, all the blood in the red tube, that's oxygenated, all the blood in the blue tube, deoxygenated. And the third item that's in your renal hilum is your ureter, okay, which is the tube that leads directly from your kidney to your urinary bladder. Doesn't that look like a beautiful all of the above question? And it's important to know that, because what happens if, you know, the fat pad and all the retroperitoneal structures and my 10th rib, especially in the posterior portion, isn't capable of holding this thing down? Like, for example, a typical acute renal failure, it's called a torsion injury, where your kidney could get ripped out of its socket or of its location. And if it gets ripped out, what are the three structures that the nephrologist or the surgeon has to go deal with immediately? Well, they're going to have to go deal with this artery, this vein, and of course your ureter. And of course, we already know if there's an artery and a vein, there's got to be a what? There's got to be a nerve associated with. So all the dirty blood comes into the renal artery. And once it goes to the renal artery, it comes in, and then it goes, if you look at it, use your imagination a little bit, there's two areas of the kidney. And this area here is called your medulla or medulla, right? And I call that the urine funnel area. And then you have your cortex, which is the outer edge, the outer area here, that has all of these blood vessels. So your dirty blood that has a whole bunch of nitrogen and ammonia and other stuff, it goes up here, and then it goes to get filtered in the cortical area, also known as the cortex. Once it gets filtered there, then it goes through a whole bunch of funnels in your medullary area. So the funnel here, this is called your pyramid. It gets supported by these columns. After the pyramid, you have this little baby funnel here, which is called your minor calyx. This is a minor calyx. And then a bigger funnel here, major calyx. And all the major calyces then empty out into the renal pelvis, which forms this part here, the first part of your ureter. So again, to recap, dirty blood goes in the renal artery, it goes in, it gets filtered out, then the clean blood goes out into the renal vein, back to the heart to get reoxygenated, and then all the urine gets dumped into, this is a renal pyramid, minor calyx, major calyx, into then what's behind all of this, renal pelvis, and into your ureter. Okay? Okay. And that's a classic picture. Again, you could easily do this, A, B, C, D, E, F, G. Okay? Now, what is going on in the cortex or the cortical region of your kidney? This is what's going on. This thing here is your nephron. It's called the functional unit of your kidney. Let's see if they have a better picture. Oh, here's a wonderful picture. You've got, like, I think hundreds of thousands or millions of them. I forgot how many. Just know these are microscopic, and there are like bazillion of them, if that's a number. Okay? So they come in through the arterial, right? And they go within the artery system, and then it ends up in a tuft, or like a big dust bunny of capillaries. And we already know that capillaries are thinned, single cell walled structures. And if it's so thin, that means blood can then do what? Can get filtered in and out of here. But what gets filtered through here, and this thing is called your glomerulus, right? Let's see if there's an arrow for it. Let me spell it so we all on the same page on what's the names of these structures. That what they call tuft of capillaries, or you'll hear this term, tuft of capillaries, which looks like one big convoluted dust bunny of capillaries. That is called your glomerulus. Okay? Now, this glomerulus, this thing right here, of course, has a glomerular capsule, also known as the Bowman's capsule. So dirty blood goes in, And right here at the level of the glomerulus, going into your glomerular capsule, the glomerulus is the location of filtration. Okay, let's put that in our little in our little side notes. So function 1 of this glomerulus and the function of the glomerulus, filtration. So it takes dirty blood and gets rid of anything extra. So if there's extra salt, we're gonna dump it into here. If there's too much sugar, it's gonna get dumped into here. If there's too much protein in the blood, it's gonna get dumped into here. But we already know typically there shouldn't be that many, right? So salts go in and out, sugar can go in and out. There's a whole bunch of things that goes in and out of here. So this is the glomerulus and this is the glomerular capsule. You now have here your proximal convoluted tubule, and the word convoluted just means it's long and windy. After you have this windy road here, proximal convoluted tubule, you also have this loop of Henle, and that is your they call it nephron loop. So let's write that down. So the loop of Henle. Okay, and then we have, you know what? Let's write down all these parts. So you have the loop, you have that, you have proximal convoluted tubule. Now, if I have a proximal convoluted tubule, I have to have a distal convoluted tubule. Wow, I can't spell. Went to school for so long, and I still have to use spell checker. So I have a tuft of capillaries called the glomerulus. Its function is filtration. I have a proximal convoluted tubule that leads me into a loop of Henle that leads me into a distal convoluted tubule. And then from my distal, so I have a proximal, then the loop of Henle, then the distal convoluted tubule, and then I end up in a urinary duct. Okay. And that urinary duct, a whole bunch of them get together, will eventually lead to my the renal pyramids that we talked about. So the first function, function 1, number 1 function is filtration. Now, in the proximal convoluted tubule and the distal convoluted tubule, you'll have other functions because this filtration function of your of the capillaries of your glomerulus is not perfect. Sometimes it messes up. Sometimes it throws out something that they shouldn't have thrown out. And sometimes they keep in the blood where things that should have been thrown out. So what does that mean? So there's something called secretion or a reabsorption. So let's say, for example, I threw out too much sugar, and then my kidneys tell me, wait a minute, I need that sugar. Reabsorption is throwing out something that you want back, hence the term right? That's the most layperson way I could think of it. Reabsorption is taking back something you accidentally threw out. Okay? Now, if I have a proximal convoluted tubule, I also have a distal convoluted tubule. And that has secretion. Secretion is throwing something out that you should have thrown out in the first place. Okay? Because we have to have these two backup systems because the glomerulus system isn't 110% perfect. So whoever built us built redundancies, built backup systems, and that's secretion and reabsorption. And most of the reabsorption happens in the proximal convoluted tubule, and most of the secretion happens in the distal convoluted tubule. Now, what does the loop of Henle do? Loop of Henle forms this thing called the countercurrent. Let's see if they can go in there. Corpuscle, nip. This is a more accurate view of your tuft of capillaries or your glomerulus. See how they go round and round and round, and they're only, and if you could see here, right, they're only a single cell thick. So that means things can easily go in and out. Let me try to find that loop of Henle. They're not going to do it. Or maybe they're going to do it somewhere else. So what does the loop of Henle do? Let's look at this. Okay, let's, which is a good one that Khan Academy. They're always good. So let's look at this video, and I'll stop every once in a while because for you future nurses, the loop of Henle and the countercurrent is a big physiologic high value topic. Or if you're one of these people studying for your MCAT, which is the medical college aptitude test, this is also a big topic.
So we've already talked about this part of the nephron, right? Remember, it's called the glomerulus, And it's the structure that receives an arteriole that's called the afferent, meaning going towards, arterial, that's the arteriole that branches off of the urine. And in this
we already went through all that. I want to get to
builders of macromolecules like amino acid, loop of Henle.
It's the loop of Henle. That's what we want.
And it's got two limbs to it, as I've shown here, and they're going in opposite directions. One is called the descending limb. Descending because it's diving deep into the kidney. So this is the descending limb. And the other part of it, this guy right here, is called the ascending limb. Ascending because it rises up, ascending limb. And the reason why this is significant is because, remember, the kidney is kind of broken up into two main overall parts, right? There's a part that we call the renal cortex, that's above here, and then there's a part we call the renal medulla, which is down here. And the thing to remember is that the renal medulla is very salty because we have a lot of ion reabsorption happening here. Now, I should further specify that the descending limb and the ascending limb.
Now, just a little side note, if you remember, wherever salt goes, water goes, right? And what's urine mostly made out of? Water. So things go from the cortex eventually to the medulla, and those are the cortex is more of the filtration part, and the medulla is more of the urine part.
Loop of Henle reabsorb very separate things. The descending limb reabsorbs water. So we have mainly water come in here. And in fact, there are no ions that are reabsorbed at this point. It is impermeable to ions. On the other hand, the ascending limb does the exact opposite. Here, we reabsorb things like sodium, chloride, potassium. And in fact, this part is impermeable to water. No water will be reabsorbed here in the ascending limb. And because of this, we have a very beautiful system that occurs as a result. This is called counter-current multiplication. Counter-current multiplication, which is also, I'll admit, a mouthful, but it completely makes sense, I promise. Countercurrent multiplication. We say countercurrent because the descending limb and the ascending limb go in opposite directions. That's why it's countercurrent. Multiplication means that when we reabsorb ions in the ascending limb here and make the medulla salty by not reabsorbing water, that drives water to be reabsorbed passively in the descending limb. And we have a video that goes into detail about transport processes in the nephron. But here, just remember that water is reabsorbed passively. So no energy is expended to reabsorb water. And this is because we have used energy here in the ascending limb to reabsorb these ions. So active transport is used here. And by actively pumping ions into the medulla and no water in the ascending limb to make it salty, we can multiply the amount of water that is reabsorbed passively because it's driven into this space around the tubule or the nephron. The space around the tubule is just called interstitium. I'll write that off right here. So this is the interstitium.
So the two things you need to know about the loop of Henle. What does it do? It has water absorption and it has ion absorption. The main ions are sodium, chlorine, and potassium, which match up to the lecture that we gave in the RAA system, the renin, angiotensin, aldosterone. And actually, these are the main ions that diuretics deal with. And what happens is that as the ascending limb goes up, more sodium, chlorine, and potassium get reabsorbed into the medullary area. Once that, and remember, wherever salt goes, water will go. So water will just naturally go in there, but it requires, you see he wrote, add the word active here. It requires energy. And what's the energy that we know? ATP, adenosine triphosphate. And it also makes sense why the kidney has a large innervation of arteries and veins, because it needs this. So the quick and easy answer for the loop of Henle, what does it do? It reabsorbs water and it reabsorbs ions. Which ones? Sodium, chlorine, and potassium. Na, Cl, and K. Right? You have a descending limb and then the ascending limb. The ascending limb deals with the ions. The descending limb deals with the water. That's the worst. That's the worst I could do to you. But if you'd like, watch the rest of this video and their associated video, because there's math involved here, and that's when it gets ugly. But for our purposes, we're anatomy physiology. We're not a math class. That's the worst I could ask you about. Like I could ask you, where's the ascending limb? Where's the descending limb? What does each one do? Now, pathology, we're not going to talk about pathology too much because you have a separate class about that. Your GFR, you should know what GFR is. GFR is your glomerular filtration rate, or what is the rate at which your glomerulus filters blood. This is one of the major indicators of renal failure. So of course, if the GFR drops or looks funky, then we know that there's problems. You also have other things that in your laboratory class you'll discuss this. But GFR, that's the number one. So here's another one. The loop of Henle. You could see where things may get reabsorbed, or how things can get secreted. Okay, remember, secretion is things that I should have thrown out the first time. Reabsorption are things that I accidentally threw out, then I put back in. And you don't need to memorize what, where, but eventually you will. Just know the definition of reabsorption and secretion. Proximal comment. This is another example of how sodium and potassium go in and out of the interstitial space. And you could see it's done by an active process, meaning it requires adenosine triphosphate, or ATP. And that's how the sodium and potassium go in and out. Okay. And here's an example of what they mean by countercurrent. When the water goes out and the urea or wastes go in, and the sodium and chloride go out, it forms this current of osmolality. meaning and if you remember your osmosis, everything goes from a higher concentration to a lower concentration. So know your definition, like not for my class, but when you start looking at this and the mathematics of it all, just always look at your basic concepts of osmosis and diffusion. And this will help you because this can get complicated. But for our purposes, only know that what? Water goes in, water goes out, right? Gets reabsorbed, and so does sodium, chloride, and potassium. Let's see if there's anything else. Autoregulation. No, I don't think we should go through that. So let's look at our objectives to see if we're on task. Did we talk about the property of urine? Yes. And the importance of urine. And what is urine? Yes. Did we talk about the structure and function of urine transport? It starts in the kidneys. We talked about the internal structure of the kidneys and the structure and function also of its internal parts, specifically the nephron. So that's the urinary structure and function, kidney structure and function. Now, the endocrine function of kidney, that let us see. Let me go back to OpenStax, see if they have something specific on that, or a nice easy chart that we can look at. Remember, it was chapter 25, was it? Urinary system, homeostasis, endocrine. Here you go. Now, the RAA system, we already know about the RAA system. And again, if you want me to go over it again, I will. But all intents and purposes is just as a quick review. The impetus for the RAA system is low blood pressure or anything related to low blood pressure, meaning low blood volume or low fluid volume or low sodium, low potassium. And then you activate the RAA system, then your blood pressure should increase due to the whole process that we talked about in the previous lecture. ADH, that's antidiuretic hormone. That's the hormone that tells my urine to don't pee. That's the easiest way to look at it. Anti means no, diuresis means to pee. Endothelin is vasoconstriction. Nice to know. Natriuretic hormones. Look at the word. Natriuresis deals with sodium, Na. That's why sodium is called Na. So it also, natriuretic hormones deal with the absorption of sodium. Your parathyroid hormone, do I want you to know this? No, I don't. Okay. And remember, your kidneys can sense volume. So, one of the main ways it senses volume is through pressure, and we already talked about the juxtaglomerular apparatus, or the JGA, in our previous diagram, previous photo. Diuretics and fluid volume. The way diuretics work, we already talked about that before. If I throw out salt, if I trick my kidney into throwing out salt, what will follow? Fluid will follow, or water. And if I throw out water and I throw out salt, what will happen to my blood pressure? It should decrease. Okay. Chlorine, phosphate, bicarb. Same thing with acid-base balance. One of the things that your kidneys do is they also produce the buffer sodium bicarbonate, which is HCO3 minus, or NaHCO3. And remember what a buffer is. The function of a buffer is either a weak acid, or in this case, bicarb, a weak base. It's to push the pH more towards the middle. and that's homeostasis. You always need the pH around 7.4, which is physiologic pH. If it goes either way, you'll have metabolic and lung problems associated with it. I've already mentioned the elimination of certain drugs. We can play with the pH of the blood. There's a reason why your dietitian and your physician make you drink that battery acid, you know, that orange juice that they have in the hospital, or the cranberry juice. That stuff, you put that on my car, probably eat the paint. Or if you're too acidic, they make you drink, it tastes like liquid phlegm. What was it, like buttermilk? Oh, it's just gross. All of that is because its function is not to taste good. Its function is to play around with the pH of the urine. And remember, if you have acidic drugs and I acidify your urine and I acidify your blood, then what will happen? It'll get acidic drugs will absorb into the urine, and then I could pee it out, and then I could remove it from your system a lot faster than normal. You can also know and understand that if my patient has renal trouble, then I have to start looking at all the meds, especially the ones that get eliminated via the kidneys. Erythropoietin, we already talked about. Vitamin D synthesis, we already talked about in conjunction of its importance with, what do you call that, skin and bones. Blood pressure regulation is the RAA system. So I think I'm just trying to look to see if I'm missing anything. I don't want to add anything. Nope. Now it's already at the end of the chapter. So those are some of the hormones that that the kidney regulates and that the kidney provides for homeostasis. So, and remember, for next week, discussion 4 is an option. Okay, if you want some extra credit, do discussion 4. But typically, there's no discussion 4 due for next week. The task for that's due next week by your exam, of course, is doing a concept map for these things that we already discussed. And last but not least, lesson 4. Oh, ooh, there's a nice video. They fixed it. Let me see if it works. Well, you can see it on your own. But what's important is the application assignment. You download the case. And part 1, questions. Part 2, I remember I didn't want all of these. Just part 1, questions 1 and 2. Part 2, questions 3, 4, and 5, and 6. That's it. That's it for next week. Because all this is math and all this other stuff that isn't important to us yet. So again, do next week. Part 1, questions 1 and 2. Parts 2, questions 3, 4, 5, and 6. That's it. Don't do the other things. All right, it is this point of the show. Does anyone have any questions regarding, there's a question. Yep, I'll be putting, for those of you who had me before, I'll be putting a practice exam this week so that those of you who haven't had me before can know what it looks like. And you could talk to your classmates who've had me before. It's a different version. It's not the same exact version, but it sure as heck looks a lot like the exam. And what is the exam based on? It's based on, if you look at every week that we ever had, there were objectives, right? Integumentary. And there were certain things that now, will you study a video that I didn't bring up? Of course not. But if I brought up a video and then, now regarding the laboratories, well, let me finish the other statement. Regarding the laboratory, if I brought up a video, right? Like, for example, Did we watch the aging process? Nah, not really. But I went through in pretty good detail things similar to this first video here, where it had all the layers, all right? And I had actual diagram of all the layers. So that should be screaming to you what? Hey, that's important. That's something that I should be looking at. And then something secondary would be this aging process, right? Let's see, let me address some of the questions. Now, regarding laboratories, if you look here, and I already got some RSVPs, but if you look here at the laboratory dates, laboratory dates are, first session is November 19th at 6 p.m. And again, for these particular session 1 and session 2, I will have I'll have video lectures for these nights. But I need an RSVP for session 1 and session 2. If you miss either one, here's a makeup one, okay? And if you cannot attend laboratory for health reasons or for any other reasons, you need to call me. You need to talk to me, okay? And that's the laboratories, and it's a separate laboratory grade, okay? And thank you for those of you who already sent me your RSVPs. But for your class, I think there's only like 6 of you, so it shouldn't be bad. But I really need your RSVP because I have to tell the administration how many people are coming each night, because there are nurses have labs that night, so does culinary. And we don't want a lot of people in the laboratories. And then once we do our laboratory, we skedaddle. We don't hang out. Try to wear scrubs if you have. If you don't, wear street clothes, and I will have lab coats and disposable lab coats. Masks are to be worn at all times. We scrub in and we also scrub out during these laboratories. So anyone have any questions on how to study, what to study? It's 50 items, multiple choice. It will be made available here. Why do I have 2 Zoom recordings? That's weird. All right. And then you just email me the answers before 7:15 p.m. For every minute after 7:15, I take a point off. But if you cannot take it at that time, there's a different version that I could supply to you, but you need to talk to me now. All right, don't call me at 5:55 p.m. Hey, Dr. Garais, I can't take the exam. That's not fair and that's not right. Okay, and I always have to say this as a public service announcement. It is a closed book exam. If you want to cheat, go ahead, cheat. But you will eventually get caught somewhere down the road when you have no idea what you're talking about, or when you have no idea what you're doing, especially in your pathology class, because they don't go over. Dr. Bettini will not re-lecture basic anatomy and physiology. She's just going to go straight right in. Okay, so and also when you want to know how you fare, and if you're into cheating, well, that's it. That's what you're into. But I can tell you right now, everyone that I know cheated in medical school got eventually caught, and they got caught in, cheating in medical school. Actually, cheating is more rampant in medical school, because you can only imagine somebody plopped down $220,000 for their education. They're going to do everything hook or by crook to pass. But the thing in medical school is that its function is not to pass everybody. Its function is to get rid of 75% of the class and only have the top 25% graduate. And because back to our ethics, what we always talked about, do you want your physician, your nurse, or whoever takes care of your family member to know only 70% of the material or 80% of the material? You want them to know everything. So with that being said, does anyone have any questions regarding what to study or how to study, or what to look at, or how to go about doing things? If not, kindly log off. Have a wonderful evening, and I will see everyone here at 6 p.m. Well, not really see anybody, but you will see a message at 5:55 p.m. The case study for week 3. Yes, the case study for week 3 is due today. Specific instructions regarding that was in the week 3 Zoom recording. I don't believe I stated to do all the questions. All right, let me see. Let's look at true. And if you didn't do lesson 3 yet, I'll get you to the end of the evening.
Yes, Professor Nelson.
Yeah, you got to do all of them.
Okay,
Yeah, they're you got
all of them in okay, and week 4.
And as I stated earlier in this evening's lecture, let me just stop the recording because it's going to get long. Hold up.